Hello, everyone. Welcome. I'm Anju Peters. I'm here with Dr. Michael Platt, and today we'll be talking about treating with precision in CRS-WNP, or chronic rhinosinusitis with nasal polyps, defining the role of targeted biologic therapy for optimal patient outcomes. Thank you for getting so quiet. Welcome. As I mentioned, I'm Anju, and we also have Mike. Thank you to PeerView for providing this session, and Regeneron Pharmaceuticals and Sanofi for providing educational grant for this symposium. If you haven't already, please complete the pre-event survey. Look for additional polling during the presentation. Submit your questions, and we will answer them during the question and answer session. In-room learners, use your personal device to scan the QR code on the following slides to respond to polls and ask the faculty questions. Virtual learners, please respond to polls on your screen and enter questions in the chat window. So for those of you who are here and learning, each action increases your chance of winning. Complete the pre-event survey, answer the polling questions, submit questions to the faculty, and if in the screen it appears you won, see a PeerView team member to claim your prize. And the prize is actually really good. I already asked. It's $50. The slides and practice aids can be accessed in the activity menu now and downloaded after the session. So the goals for today, during this presentation, we will learn that the underlying mechanisms of CRS-WNP influence its clinical presentation and patient impact and can guide treatment selection. Key clinical indicators help identify patient eligibility for biologics, which may be considered before all traditional options are exhausted. Treatment should be individualized, incorporating biologic therapy when appropriate as part of personalized care plan, and biologic effectiveness should be monitored with evidence-based follow-up, setting expectations, addressing misconceptions, and adjusting therapy as needed. So as I mentioned, I'm Anju Peters. I am an allergist at Northwestern University Feinberg School of Medicine in Chicago, Illinois. And we're joined by Dr. Michael Platt, who's Vice Chair for Education and Associate Professor, Department of Otolaryngology, Head and Neck Surgery at Boston University School of Medicine in Boston, Massachusetts. We are both very excited to be here. Let's start. So defining chronic rhinosinusitis with nasal polyps, many of you are familiar. In addition to symptoms, which should be there for 12 weeks, and at least two of the following, so 12 weeks or longer, either abnormal drainage, either anteriorly or posteriorly, nasal obstruction or blockage, facial pain, pressure or fullness, and these patients complain of loss of smell or decreased smell, which can really affect their quality of life. In addition to symptoms, they should have some objective findings of inflammation, either by endoscopy, and here you could see that, or by a sinus CT scan. So in terms of CRS-WNP, about 12% of the adults would meet the symptom criteria for CRS. Typically, these patients present sometime in their 30s through 60s for nasal polyps. Nasal polyps are more common in men by a bit than in women, although studies suggest that women may have more severe disease. So let's talk a little bit about immunology, as we're going to be talking about biologics. So when we think of our immune system, or endotype, the inflammatory basis of disease, we have type 1, type 2, and type 3. Type 1 includes cells like NK cells, Th1 cells, macrophage cells, CD8 positive T cells, and the classic cytokines would be interferon gamma and IL-12. We know type 1 inflammation is important to fight viral infections. Then type 2, which we'll focus on today, the cells would be eosinophils, mast cells, basophils, ILC2 cells, the classic Th2 cells, and the classic cytokines are 4, 5, and 13. We know type 2 inflammation plays a role in allergic rhinitis, asthma, and more importantly, CRS with nasal polyps. And then finally, type 3 inflammation is the more neutrophilic, associated with IL-17, IL-22, and important against both bacterial and fungal infections. So this as a background in immunology. This is what we think of when we think of CRS, WNP, and also asthma, many of our airway conditions. Here is the lining, the airway epithelium. It's faced by many things, including allergens, bacteria, pollutants, viruses, etc. The epithelium is not only just a barrier, it's actually an inflammatory organ, releases these type 2 inducers or alarmin, TSLP, IL-25, IL-33. These then activate this ILC2 cells. In addition, you're getting inflammation here with dendritic cells making Th0 to Th2, which then activate B cells. All of this leads to type 2 inflammation with IL-4, 5, 13 we talked about earlier. IL-4 and IL-13 play a role in IgE production, which then can sit on mast cells and degranulate mast cells. IL-5 is important in eosinophilic inflammation. We know eosinophils are important for CRS-WNP. And then IL-13 plays a huge role in mucus secretion also, in addition to IgE production. So remember all of this immunology. So when we think of this inflammatory basis or endotype, I'm really lucky. This is work done by led by Atsushi Kato at Northwestern, where Whitney Stevens, my junior colleague, and I actually went through charts. Literally, we went through hundreds of charts, and what we found was, if you look for inflammatory endotype, red is type 2, green is type 3, the blackish color is type 1, and here you can see almost 55% of all CRS is type 2. When you look at width NP in Chicagoland area, and this has been shown in Western population, more than 80% of CRS-WNP is type 2. You see other things, including mixed inflammation, and here you could see it's 87% is type 2, 18% is type 3, and about 17% is 1. So there can be mixed, but what you need to take away today is that majority of CRS-WNP is type 2 inflammation. So before we move on, please take a moment to answer a follow-up poll on moving beyond a symptom-based diagnosis of CRS-WNP. So CRS-WNP, which is about 20 to 25% of CRS, and we discussed 12% of the population might at least have symptoms suggestive of CRS. What we do know about CRS-WNP is that it really significantly impacts quality of life. We already talked about the nasal symptoms. In addition to nasal symptoms, we think of the one airway. We talked about that earlier. These patients with nasal polyps often get worsening asthma and is associated with severe asthma, as I showed you before. They can often complain of ear symptoms like ear pain, pressure, fullness, and unfortunately also impacts their quality of life mentally. They can have depression, anxiety. They don't sleep well. If you don't sleep well, you're always tired. You don't perform as well at work and potentially school. Think about it if you can't breathe. So we know over 50% of patients with CRS-WNP have comorbid asthma. The prevalence of asthma in US population is about 8 to 10%, so much more common if you have nasal polyps. And CRS-WNP is associated with adult onset asthma rather than childhood onset asthma. The CRS-WNP and asthma group, so if you have both, you have more severe type 2 disease, often more severe asthma, more severe nasal polyps. And up to 26% of patients with CRS-WNP can have AERD, which is aspirin-exacerbated or NSAID-exacerbated respiratory disease. These are the patients that not only do they have asthma, they most often also have Not only do they have nasal polyps, but they often have asthma, and if they were to take a nonsteroidal like ibuprofen or aspirin, they get worsening nose symptoms, worsening lung symptoms, and often are some of our most severe asthmatics and most severe CRSwNP patients. So let's go over a case. This is John. He's 38 years old. He's been struggling with chronic nasal congestion, facial pain, pressure, diminished sense of smell for the past 18 months. His symptoms started subtly, but over time they have significantly worsened. Despite using over-the-counter antihistamines, which many of these people do, and nasal decongestants, his nasal blockage or obstruction and sinus pressure persists. And he continues to experience frequent sinus infections. John's medical history includes asthma, which is not well controlled, with his current inhaler regimen including budesonide and formoterol twice a day, and as needed for rescue. He uses his rescue almost daily, which is not good. He's been treated with oral steroids twice in the past year for worsening asthma. His daily life is now deeply impacted by these ongoing symptoms as he struggles to balance work and home life while coping with his condition. So something that we all see regularly. Here is his lung function. His FEV1 is 2.45 liters, 75% predicted. So based on different ways of looking at mild to moderate obstruction, his FVC, which you'd expect it to be normal in asthma, is 90%. The ratio is 0.61, so not good. He shows airway obstruction. His Z-score is minus 2.25, again, classic asthmatic. His FeNO, exhaled nitric oxide, is 70, elevated, suggesting type 2 inflammation in his lungs. His eosinophils are 600. His IgE is high at 400. And his skin test is positive to Alternaria, a mold associated with more severe asthma and grass. So in John's case, do John's symptoms align with CRSwNP or another condition, as was asked this morning? I would think so, both with asthma and nasal polyps. Is there relevance to his comorbid asthma? I would think so. How does that complicate diagnosis and treatment choices? He has more severe disease. What diagnostic tool should we utilize now? We'll actually talk about that a little bit later. Mike will talk about that. What I do want to show you is one more slide on impact of quality of life in patients with CRS with nasal polyps. On the left here, if you look at SF36, which is a good way of looking at quality of life, here looking at physical component and mental component, patients with CRSwNP are in orange and have worse quality of life, both mentally, physically, compared to population norm. Here looking at patients with asthma, CRS with nasal polyps with asthma in green, patients with nasal polyps without asthma in orange. The dark blue is population norm, and purple is the group with AERD. In Europe, they call it NERD. And as you can see, both physical component and mental component is worse if you have AERD, but also bad compared to population norm and even general CRSwNP patients if you have comorbid asthma. So actually, it showed up here. This was what I was hoping you would discuss, but I can discuss it, or you can. Do you want to discuss it? I'll just do it. So the different tools in CRSwNP, although as ENTs, he probably uses nasal polyp score more than I do. I use it only for clinical trials. You can do NPS or nasal polyp scores, which is endoscopic grading of polyp size, 0 to 8, with 0 to 4 on each side. The higher the score, the worse the disease. MCID, meaning clinically important difference, would be decreased by 1 or 2 points in your polyp size. SNOT-22, or sinonasal outcome test, many of us use. Quality of life questionnaire across different domains, including nasal, sleep, and emotional, ranges from 0 to 110. The higher the score, the worse the disease. MCID here is about 9, so decrease in 9 would be clinically meaningful. VAS, or visual analog score, I use it often. This is patient-rated symptom severity. You could rate it from 0 to 10. Here, decrease in 3 or more suggests moderate improvement. And then there are different ways of testing smell, upsits, sniffing sticks. In US, we tend to use them mostly with our clinical trials. In Europe, they tend to use it in regular practice as well. Okay, I should have let you go before. Please go ahead and add whatever you need to.
We have a long list of medical therapies we use for chronic sinusitis with polyps, and the mainstay is with topical therapies. First of all, nasal saline irrigations, high volume irrigations on a regular basis. There are many different types of delivery devices. Traditionally, it was a neti pot, a squeeze bottle, electronic devices, whatever it is. It's high volume to clear out the nasal passages, remove all those inflammatory mediators, mucus, bacteria, anything that's bad must go. Next up, topical steroids, and there's many ways to get topical steroids in the nose. Traditionally, this was with the intranasal steroid sprays, and there's many different names, varieties. Many of them are over the counter, they're easy to get. How can we get higher doses? There's one proprietary exhalation delivery system where you blow in the steroids at the same time that you actuate the pump. It gets the steroids a little higher in the nose, further back, up into the sinus cavities. There's also sinus steroid-eluting implants that you can have placed in the office. And then there's off-label steroid irrigations, budesonide irrigations, by placing the same budesonide as you place into your nebulizer, you place into the saline irrigation bottle, gets higher doses of steroids into the sinuses. These topical therapies are the mainstay of CRS with NP treatment. Antibiotics have been studied, and it's not really clear that they're helpful for CRS with NP. Now, if you have an acute exacerbation, there's evidence of purulent drainage, you think you have an acute bacterial process, it's a possibility. And there's some data that perhaps long-term macrolide therapies are of some benefit. But it's an option. It's not a must, and it doesn't make a huge difference. Same with leukotriene modifiers. There's some evidence that it can help, and it is listed as an option in the ICAR guidelines. But it's not going to be a huge difference, and you have to be aware that there is a black box warning for allergic rhinitis on it, for psychological side effects. And so it's generally not something that's used that often, at least in current practice. Systemic steroids work. Prednisone works in short bursts. But we all know it has so many side effects and risks. It's never really cured anyone. It's a temporizing factor, or what I call a stall technique. You know, it puts off doing something else. And so we're left with the mainstay being the topical therapies. CAT scan as the gold standard for objective assessment is often used when making a decision to do surgery and to do surgery planning. There are other indications when you're unsure of a diagnosis and you're trying to rule in or rule out. It can also be used in that factor, but generally it's used as a surgical planning tool. MRI scan can also show you the sinuses in much more detail, especially with the soft tissues, and it's often used when we're talking about complications of sinusitis, extent beyond the sinuses into the skull base or the eye, or if you're concerned if there's a tumor, but it's not a general study that we would get for usual CRS. And there are lots of different interesting, promising AI tools that are trying to endotype based off of imaging, but they're not ready for prime time yet. So let's get back to John here, 38-year-old man. You do a nasal endoscopy in the office, and this is what you see. Bilateral nasal polyps. These are pale, smooth, watery. You don't see any purulent drainage. We already saw that he has elevated IgE. He has elevated eosinophils circulating. He actually underwent 2 rounds of antibiotics for acute exacerbations, which were felt to have a bacterial component. We heard earlier that he already was on 2 rounds of oral steroid bursts for his asthma in the past year. And he's frustrated, anxious, isolated, quality of life declines despite all of this medication. He's considered surgery, but he's worried about the relief will be temporary, and he's looking, hopefully, for something that would help more long-term. Sinus surgery is standard of care. Wonderful, wonderful procedure that helps so many patients with this disorder, and it helps in many different ways. Number one is by taking out the polyps, you're reducing the inflammatory load. All those inflammatory mediators that we saw on the previous slides and those beautiful immunology slides, those are sitting in the polyps. And if you remove them, you're just debulking your body of all that inflammation material. Removing the polyps, opening the sinuses, also allows for normal sinus drainage. You want the sinuses to be able to have mucociliary clearance, to be able to bring normal mucus out through the nasal cavity, through the sinuses. You also want to be able to monitor. After someone's had sinus surgery, you can take an endoscope very easily in the office and have an excellent monitoring of all the different sinuses. And the most important, I think, is that you then, when opening the sinuses, allow for topical delivery of topical steroids and saline much more effectively than you would without having surgery, without having open sinuses or having polyps in the way. And so sinus surgery is really a wonderful treatment for patients, for the majority of patients who have this disorder, but it's not a cure. And the studies vary in terms of outcomes. When do polyps recur? And it's a hard thing to say because you don't know a polyp is there until you can see it. And how can you see it? Well, it depends on how closely you're looking and when you're looking. It also depends a lot on the postoperative regimen that patients are doing. Are they using topical steroids? Are they using topical saline? At what dose of topical steroids do they use? Generally, surgery is not a cure for the vast majority of patients with this disorder. It helps, but the underlying disease is still there. Surgery cannot remove all of the disease. Why? Well, you need normal mucociliary clearance. You need to have mucosal covering of the normal structures, the lamina papracia to the eye, the skull base, the turbinate. These are structures that are important for normal, healthy functioning of our sinuses. And so you can't just take out everything. You take out the disease. You want to have open, patent sinuses that can then work, hopefully well, and get topical delivery. And so looking at these studies, it does go up over time. The polyps grow back. And there are some centers who are doing more aggressive surgery. Here we see here, draft 3, reboot, more aggressive surgery to make really, really wide openings into the sinuses. And I think that this has been a little bit less in vogue now that we have other treatment options like biologics. But it makes a very good point in that when you do a surgery for these patients, you want to do adequate openings, big surgery, take out all the partitions. When you do sinus surgery, there's a lot of subjectivity into how much you take out. And generally with these patients, bigger, wider open sinus cavities that can drain better, that can be irrigated better, that can be monitored better, is better than minimal surgery. And there are different opinions in this, but in general, you want to have an adequate surgery that allows for topical delivery. Patients that have type 2 inflammation generally have more severe disease and faster recurrence of symptoms after surgery, especially those that have asthma as well. Even the patients that do well, a lot of them are still uncontrolled. And that means that they have persistent symptoms despite maximal therapy, and this generally increases over time. This one study said it was at least 40% may still be uncontrolled. It's a high number. I'm not sure that I would go that high, and it depends on many different factors, including what the topical steroid regimens are. The point is that at 12 years, about 80% have recurrent polyps. It's not 100%. There are patients that you do surgery and the polyps don't come back, and we don't really understand why. But the vast majority are going to have polyp recurrence. And many of them undergo a revision surgery. And many of them are very happy to undergo a revision surgery because it helped. It made them feel well, and for a number of years they did well afterwards. The polyps came back, and they're ready to do it again. Dr. Peters, back to you.
So let's talk a little bit about mechanisms of actions of targeted biologics in CRSwNP. You saw earlier a version of this. This now shows the different biologics. So remember, here was the airway epithelium, which is not just a barrier against all of these different allergens, et cetera. It can lead to production of inflammatory molecules. The one that's most important for us here is TSLP, which then leads to, again, those ILC2 activation, type 2 cytokines. Tezepelumab is the newest biologic that's approved for CRSwNP and targets TSLP. Omalizumab is our oldest one. It's been around for like 20-some years for asthma and also approved for nasal polyp. It blocks IgE, so the IgE does not go sit on mast cells and basophils. Dupilumab, and the newer one that's not approved in US but was published in, I think, JAMA last year, the stapokibart. I don't know if I might even say it right. Someone else can pronounce it right. Blocks both IL-4 and IL-13 signaling. And then meplizumab blocks IL-5, which decreases eosinophilic inflammation. Depemokimab, which we'll talk about in a few minutes, also blocks eosinophilic inflammation. So currently approved biologic therapies, dupilumab, it actually is approved for many different conditions, including asthma, atopic dermatitis, eosinophilic esophagitis, eosinophilic COPD, chronic spontaneous urticaria, prurigo nodularis, in addition to atopic dermatitis and bullous pemphigoid, so a lot of skin conditions. Omalizumab is approved for asthma, as I mentioned, our oldest one, but also for chronic spontaneous urticaria, and more recently, food allergies. Mepolizumab is approved for eosinophilic asthma for 10-some years, also for EGPA, which is something that we, both allergists and ENT, see, hypereosinophilic syndrome and eosinophilic COPD. And then tezepelumab is approved for asthma in addition to nasal polyps. So when do you initiate biologic treatment for patients with CRSwNP? You know, some of this we have guidelines to help for it. We select biologic, we have to monitor its effectiveness, predict response. We don't really have good biomarkers. The most important thing is you confirm that someone does have CRSwNP. I think this should be done in a multidisciplinary manner. If I, as an allergist, see a nasal polyp, and I see them frequently, and if I see them bilateral, I still work with my ENT colleague to make sure my patient gets the best view of possible treatment options. So you confirm the diagnosis, you check for comorbidities, asthma, AERD, allergic rhinitis, which we're not talking about here. Check that type 2 inflammation is likely, and we'll talk about that in a bit. Inform your patient of treatment options, perspectives, and risks. This is, I think, a big shared decision-making thing that there are tools, including American College of Allergy, Asthma, and Immunology, which can help you with this. And then decide whether surgery, biologic, or both for your patient. With your patient, you make the decision and select the right biologic drug for your patient. For CRSwNP and asthma, important to work with your colleagues that manage asthma to make sure we're choosing the right biologic. Here are one of the guidelines that are widely used. This is from Euphoria, and this is European guidelines, but I think these are pretty good for us too. It's important for my allergy colleagues. I always say make sure you have bilateral nasal polyps. In the last 6 months, we had a patient with unilateral who actually it was melanoma. So presence of bilateral polyps, our European colleagues say in someone who's had surgery, they suggest 3 criteria are required. Those criteria include, oops, sorry, I didn't mean to do that. I knew I would do that once at least. There we go. Evidence of type 2 inflammation, how do you do that? You could look at tissue eosinophils greater than 10 high power field, or blood eosinophils greater than 150, or total IgE, which is not that sensitive or specific, but greater than 100. Need for systemic steroids, telling you it's severe disease or contraindication systemic steroids. Most of us feel 2 or more courses in a year, and obviously if they're on it chronically, which we used to see that before biologic era, I feel. If they have impaired quality of life, which the best and easiest way is SNOT 22 greater than 40, significant loss of smell. In the US, we base it on history, but you could do one of the tests. And then diagnosis of comorbid asthma. In case of asthma, regularly needing inhaled steroids. So you need to meet bilateral polyps, history of surgery, and at least 3 of these criteria, according to our Euphoria guidelines. Ask and answer questions to earn more chances to win your $50 gift card. Before we move on, please take a moment to answer a follow-up poll on eligibility for biologic therapy. You guys should have this, so hopefully you don't have to keep taking pictures.
We can look at this published algorithm, and there are many of these that exist out there, but this is a really nice one of how do we treat patients with CRS with NP. The majority of patients here will get offered sinus surgery, and in an individual way, discuss the extent of surgery tailored to that person's disease. And following surgery, they're going to get topical therapies, which always consist of saline irrigations and steroid in some way. Not always, sometimes it needs to be increased as you go, but at the very minimum, a topical spray. There are patients, despite doing outstanding perfect surgery and outstanding perfect postoperative care, have persistent symptoms, persistent disease, quick return of polyps and inflammation. And those patients who don't do well with surgery, we already talked about increasing the topical steroid dose through either a steroid irrigation or an exhalation delivery system. But if they don't do well, you have this shared decision-making option list here. First here is biologics. Biologics work extremely well for these patients, and you also could consider the comorbidities about which biologic to prescribe based on a comorbidity. Revision sinus surgery is an option, but to think that if you did a surgery and 6 months later you're going to do the same surgery and it's going to have any different outcome, it's not usually a great idea. Now, if someone had inadequate surgery, they had minimal surgery, you could say, okay, let's do an appropriate maximal surgery to get things as wide as possible. If it's been a number of years and they did well for a number of years, you could say, okay, let's do it again, and hopefully we'll have an equally good outcome. However, if it doesn't go well, and it happens to the best surgeons, biologics is a much more successful way to treat this than a revision surgery. Aspirin desensitization, I used to see a lot of it. The biologics work so well for the AERD patients that I really don't see patients going through this anymore. And there's side effects to having aspirin long-term and high doses. And so I think that biologics has almost replaced aspirin desensitization. Steroid implants are an option. Consider short bursts of oral steroids, which temporize, but generally don't cure. Now, what happens about, if we go back to the top here, minority of patients, so who does not get sinus surgery? If there's some contraindication to surgery, and so medical disorders, anticoagulation, medically complex, can't have anesthesia. Poorly controlled asthmatics. You're not going to find an anesthesiologist who will even put your patient to sleep until their asthma is controlled. And oftentimes it takes a biologic to get their asthma under control. And so many of these work for both CRS with NP and asthma. And finally, you can't force the patient to have surgery. This is shared decision making. It's an option. If you look at the FDA approved label on the biologics, it says for inadequately controlled the failure of topical steroids, but that says nothing about you must have surgery. You can't force a patient to have surgery, and they are welcome to decline surgery. And at that point, you can consider a biologic. So let's go back to John. Treatment options were discussed. Surgery and biologics were both discussed. John said he wants to avoid having surgery. He made that decision and wants to learn more about biologics, which can be very helpful for uncontrolled CRS with NP, especially considering that he has asthma that's also uncontrolled. Here are the 4 FDA-approved biologics. We have dupilumab, omalizumab, mepolizumab, tezepelumab. And this is comparing the outcomes. Now, the top one here, these are the nasal polyp scores. That's that 0 to 8, 4 per side. And this was a primary outcome. Right, we started at baseline placebo 0, and dupilumab here looks like it has a decrease in polyp size by 2 to 2.5, a significant decrease in the polyp burden. For your reference, a 4 would be completely obstructed, polyps down to the floor. A 1 would be very small polyps high up in the ethmoid. So to get a 2.5, you're basically taking polyps that are near the inferior turbinate of the floor and pulling them up above the middle turbinate, so significant improvement. You can see that all of the biologics have improvement for nasal polyp score. Here, omalizumab looks like it has about a 1-point improvement in nasal polyp score, same for mepolizumab. And tezepelumab also has a big increase here, around 2-point improvement in nasal polyp score. Nasal congestion score is often done by a 0 to 3 scale, although you can have a larger Likert scale, and so it makes it a little bit difficult to compare these. But the point is that they're all significant. They're all significant improvements. That's how they achieved this FDA approval. And so all 4 of them look like they help patients. Here's the first head-to-head trial comparing biologic efficacy and safety in patients with CRS with NP and asthma. And this was a comparison of dupilumab to omalizumab. We can look at nasal polyp score here, And there's a significant difference. Dupilumab, like the prior studies, has a much bigger improvement. It outperformed also on sense of smell, an 8 or 9 point increase in UPSIT scores, and SNOT-22, quality of life outcome, significantly beneficial for dupilumab over omalizumab. Dr. Peters, you want to talk about emerging therapies?
So in terms of emerging therapies for CRSwNP, I kind of mentioned depemokimab earlier. This is the ultra-long-acting anti-IL-5 agent. You can inject it every 6 months. That's what the study was, phase 3, Anchor 1 and Anchor 2. And they did show improvements statistically significant in co-primary endpoints of nasal polyp score and nasal blockage. It is very well tolerated. It recently got approved for asthma in the US. It got approved for both asthma and NP in UK and I think elsewhere in the world. And then I'm going to say this again wrong. Stapokibart. I don't know, Mike.
I
to
have
say
no
differently.
idea. That was the first time I heard it.
It targets anti-IL-4 and IL-13. We actually did an editorial for this for JAMA for their phase 3 studies, which were Crohn's 2. And it showed among patients with severe CRSwNP who were on intranasal steroids, all of these studies, patients were on intranasal steroids, that this drug reduced polyp size and severity of nasal symptoms at 24 weeks. The serious AEs were rare. There were higher rates of arthralgias and hyperuricemia in the drug versus placebo. So this, we have now multiple drugs. How do we decide which one to use? We have some guidelines, and this is an indirect comparison of the phase 3 studies that was published late last year in JACI by Brian Lipworth. And here you can see, on top is depemokimab, below it is benralizumab, which is other anti-eosinophil biologic approved for asthma. It targets anti-IL-5 receptor, alpha. SYNAPSE study was with MEPO, anti-IL-5. Sinus 52 and 24 were dupilumab. Polyp 2 and Polyp 1 were omalizumab. And Waypoint was the most recent phase 3 study that was published in New England Journal for tezepelumab. As you can see, when you look for changes in nasal polyp, the two, they all work, but the two that did the best when you do indirect comparison are tezepelumab and dupilumab. When you look for nasal congestion score, again, all the different ones are compared. Here you can see they all got better, and here it's much tighter. Many of the confidence intervals are overlapping. Here is MEPO, here's dupilumab, omalizumab, and tezepelumab. It does appear, even though they have an overlapping confidence interval, that Tezi and Dupi were superior. They did also the indirect comparison for loss of smell score, as well as UPSIT, another way of looking at it. In terms of loss of smell score, the ones that did the best were Dupi and tezepelumab. And in terms of UPSIT, again, Dupi and tezepelumab. So here's some indirect comparison. There are little differences that you can look at in the studies and different guidelines to help decide which biologic to use. The bottom line is we are so lucky that we now have 4 different options. You also, when we see patients, especially important and with my allergy colleagues, because we manage a lot of these conditions, it's important to know what comorbidities and what other conditions they treat, because then you could potentially treat 2 diseases with 1 drug. And as you could see, they all treat more than nasal polyps.
These patients are generally more severe and more complex, and there are many different specialties that care for them: pulmonology, allergy, immunology, ENT, primary care. It's so important that we collaborate to provide our patients with the best care possible. And so I often have discussions with my colleagues, and I have both pulmonologists and allergists, immunologists that I work with about selecting the right biologic therapy, tracking them, following them along with them, because they're often managing the asthma at the same time that I'm managing the sinusitis. So collaboration is a really important thing for all of these patients. Okay, before we move on, please answer a follow-up poll. What do I tell patients about what to expect? The biologics generally work pretty quickly. Patients have improvement in symptoms, including congestion, their sense of smell improves. I could see polyps shrinking. I generally don't look that closely, but within the first 2 to 4 weeks, patients report improvement. And the improvement generally continues over the course of months. I generally follow them out until about 6 months to see how they're doing, to see if response is adequate or not before considering other things. And while they're ramping up on this, I do continue topical therapies alongside, saline irrigations, topical intranasal steroids in some fashion, and generally wait till about 6 months before making a decision whether to stop or change. It's important to set realistic goals because as wonderful as these biologics are for our most severe patients, they generally don't cure the disease, so I don't expect 100% improvement. And it's variable. While many patients do really well, some patients don't respond. I've seen patients who didn't respond to 3 different biologics and responded to a 4th. And so you realize that there are many different endotypes, phenotypes, subtypes out there that we haven't yet understood. And so you may have to do a little bit of trial and error. How do you define response? Well, if the polyps are getting smaller, patients are feeling better, not using oral steroids, that would be an excellent response. Many patients have a middle of the road, a moderate response, and it's pretty clear when it's not working. The patients will tell you it. They just basically have no improvement in their symptoms, and they're very happy to discontinue treatment. That's very different than the patients who have an excellent response. They will not stop. They are so happy. The happiest patients, I think, in my practice are those that respond after many years of misery, and there's no way that they're stopping. It's just probably one of the most important things in their lives to keep them happy, breathing well, sleeping well, enjoying food. So what about John? Let's get back to John. He wanted to try mepolizumab and had some initial improvement in congestion and severity of pressure, but by 6 months was still having significant symptoms, and the sense of smell really never came back. Please answer this question on the poll. So John was switched to dupilumab, and at the 6-month mark, he was actually doing much better. Satisfied with treatment, he had improvement in nasal obstruction, sense of smell was better, asthma was controlled. Also, reduction in the need for over-the-counter medications. And I do have patients that respond really well that will even stop their topical therapies. And often I find that at a follow-up visit, they say, oh, I stopped all that, I just don't need it, and they can't convince them to do otherwise. And you could look in there and still see evidence of disease, but if they're happy and doing well, oftentimes that's what drops off. John's follow-up appointment confirmed, nasal polyp score decreased significantly, congestion was now at a level that allowed him to go about his day with minimal disruption, quality of life markedly improved, reduction in emotional toll that his symptoms had previously caused. And so now what? He's been on it. It's FDA approved for every 2 weeks. Is he going to be on this for life? This was a study from Brigham and Women's Hospitals of the AERD registry, and a large number of their patients decided to decrease their dosing, increase the intervals beyond every 2 weeks. And this is what it looked like. At 24 weeks, patients, instead of doing it every 2 weeks, started doing it every 4 weeks. And then 24 weeks later, some of them went to every 6 weeks, and then every 8 weeks, and even every 12 weeks here, far out. And that is much different than the FDA-approved label of every 2 weeks. And in my practice, I've gone every 3 weeks, I've gone every 4 weeks, but 12 weeks is really far out. You wonder, is there anything left? But if you look at the outcomes, and they even broke it down by all the specific symptoms, the patients did well until 24 weeks, and that improvement that they had at 24 weeks lasted despite the tapering. So really interesting. No one knows, when I ask the question, how long are they going to be on it? No one knows the answer to that. But it appears that tapering is safe and can continue the effectiveness going out further. And so in summary, CRS with NP is a chronic type 2 inflammatory disease leading to the hallmark symptoms of congestion, pressure, loss of sense of smell, polyp formation. Biologic therapies are targeted precision treatments for uncontrolled CRS with NP, especially in those patients that are most severe, the ones that have frequent relapses and comorbidities, especially asthma. Shared decision-making and setting realistic goals are crucial to managing expectations and improving adherence to treatment plans. We now have a Q&A session, and we'd like the people to use their app to submit questions, and we'll be able to monitor them here and answer them, and that will help the remote people also be able to hear and see the questions. All right, do we see any questions yet?
Yeah, we have a few questions that we can start with. May I ask you, and if you want to answer this one? If you want to come on over.
Are we looking at the first one? In patients who are responding very well to biologics, how do you determine if you want to back off their nasal regimen? In which order do you typically back off topical steroids versus rinse, or do you just continue it indefinitely? Well, if I had to compare the two of them, I feel like nasal saline irrigations is probably something that everyone in the world should do twice a day forever, like brushing your teeth. Doesn't cost anything, doesn't cost much. It only takes bad things away. There's no risks. I just think it's part of daily health regimen. And so that's one that I think is an easy one to continue. The reality is, do they need intranasal steroids? Even though they're safe, there's some costs involved, and there's some question of maybe long-term if people have glaucoma or cataracts, if some steroids could diffuse and if have an effect in the eye. So that's the one I would stop first. And patients who are doing well, I do try stopping it. And they've been on it for 6 months, they've been on it for a year. I just don't know if it's necessary. They're doing so well that it's not really necessary. I do try stopping it and see what happens. But the saline, why not? I mean, all right. Another question?
I could take this one.
Yeah, go ahead.
The question is, how often do you actually get labs to decide if a patient will receive a biologic for polyps? So when I see a patient with CRSWNP, I'm an allergist. Comorbid allergic rhinitis is very common, so I skin test them at that first visit. Depending on what I decide and how severe their disease and asthma, then I will check a CBC with diff and an IgE. In an asthmatic, when I first see them, I do a spirometry as well as a pheno because it does guide us. If they do well, then we're good. But if I'm going to do a biologic, I definitely would do a CBC with diff and an IgE to help guide you. Once they started, I don't always check it. Occasionally on dupilumab, if I'm concerned because they're pre-starting dupilumab, eosinophil was high on the higher side, over 1,000, then I'll check it again 8 to 12 weeks and follow that. Otherwise, I check it right before.
The next question, if nasal polyps are likely to reoccur, why are biologics not recommended concomitantly or prior to surgery, especially for AERD or asthma? I would say that the majority of patients who have sinus surgery for this disease do well and have successful outcomes with just topical therapies. And so the question is, then why would you add on a very expensive immune-modifying medication for years when you don't need to? And so we don't know why some patients do so well and others don't. Now, it's true, the most severe patients, and even AERD patients, are not all equal. I have AERD patients that did well after surgery and didn't require any additional treatment. One day we'll know why the difference is. What is the subtype, the endo-type? But we don't have that now to predict it. And so if you're talking about revision surgery, someone who already didn't do well, yes, sometimes we do that. We put on biologics. And I have patients who are on biologics who are feeling great and still have obstructive polyps and wanted procedures just to get rid of the obstructive polyps for nasal obstruction and still do really well. And so every patient's different, but in general, we do it stepwise.
I can take the next one. When a patient comes in requesting a specific monoclonal antibody, and yeah, they do see TV advertisements, and it may not be your first choice, do you go with their choice?
It's shared decision-making that computers.
It is. So let me tell you how I do go about it. And this is all published, so you can do it too. So with most of my patients, actually, there's a paper from Paul Oikman from Canada, and we used it in our practice parameters guidelines for CRS-WNP. It was prior to tezepelumab approval, so then I have to put in an extra effort. But I show my patients that table on the computer and go over them, that here are the patient-reported outcomes that I think are important to you: sense of smell, quality of life, congestion, need for surgery. Then there are things that are necessary to get approved: polyp score, CT scan. And then we go through and say which study, the best evidence, what we have for benefit for what is important to the patient. And then I also go over their comorbidities. I tell them, our biologics, we're lucky. For asthma and nasal polyps are very safe biologics. And the difference between them are, safety-wise, really not, they're all really safe. And then based on what a patient wants, shared decision-making, if smell is really important to them, then I show them that dupilumab and tezepelumab had the best smell results. I think they most often, after thinking about it, then I write everything out for them. They go home, they can think about it. They kind of agree most of the time.
Well, Dr. Ryan asks, do you really think that a biologic should be tried for 6 months before assessing response? It depends on the patient. The answer is, what you're asking is no. If it has no effect, then I'm not going to wait 6 months. If it has a partial effect, then I am. And so if you just have a non-responder, you're going to know it much sooner before that.
He wanted me to answer too.
Oh.
Sorry. Also, I had to put in, so that I will tell you I totally agree with Mike. I think 3 months tells you pretty well.
If it's a partial response, you don't know if you're going to get more.
Agree.
Next question. Is there potential for nasal topical biologics, similar in theory to the atopic derm biologic creams? I'm not aware of any, and from a mechanistic standpoint, there are two issues. One is we're trying to get inside the polyp, not on the surface. We need to get to the inflammatory cells deep inside. And the second is it's always been a challenge getting topical delivery to the sinuses, right? You need to have even with the best big wide open sinuses, how much do you actually get to the posterior ethmoid? How much do you get to the sphenoid? How much do you get into the frontal? Probably nothing into the frontal, right? And so topical delivery is important and difficult. And even if we had a biologic that was able to get absorbed, I don't think it would get absorbed to all the places it needs to get absorbed to.
I'll answer this one. Jamie asked, for a patient who becomes pregnant, do you leave them on the biologics? I think this is a really good question, especially because we see polyps in patients with severe asthma, so this comes up often. We go over the risk benefits of the biologics. We go over the risk benefits of potentially needing systemic steroid exacerbations. I will put this with asthma and polyps together. We definitely know that the asthma needs to be very well controlled in the mom for the fetus to do well. And so when we talk about that, we obviously leave them on inhaled steroids, topical steroids. But if their asthma is severe enough or their sinuses are severe enough, we go over the different biologics. Omalizumab actually has data on asthma being safe. There are studies. You'd be surprised, but maybe you're not surprised. The other companies also have gathered data. So GSK has really good data. Sanofi Regeneron has really good pregnancy data that has not been published, I think, yet. But I did most recently on a patient with severe eosinophilic asthma and nasal polyps who was doing very well with mepolizumab. I actually reached out to GSK. They shared, and this is, of course, non-FDA, I'm telling you my opinion. They shared with me all their different data and studies. And I asked them, and they actually let me share it with the patient and her husband. The patient's aunt is a scientist. She, for a while, went off. So, ideally, we take them off the biologics. When she was off the biologic, literally, her lung function dropped. She needed 3 courses of systemic steroids. In the end, she went on mepolizumab. She just delivered her baby, and the baby's doing fine. She's doing fine. Similarly, my AERD patients who are really severe asthmatics with bad nasal polyps, we'd had a discussion, and I've had more than one AERD patient stay on dupilumab, others on omalizumab. Really, it is shared decision-making that's important. It's patient-specific. In general, most pregnant patients, you don't want them to be on anything more than is absolutely necessary. I hope that answers the question.
Yes. Next question. When you discuss biologics with patients, what potential and reported risks and side effects do you discuss, and how do you frame the discussion? The risks that I go over are things like potential for a severe reaction, potential for a local reaction or symptoms at the injection site. There are arthralgias that can be seen. There's conjunctivitis with dupilumab that is more often seen in patients who have atopic dermatitis. For some reason, that's a little bit different type. We generally don't see it with CRS. I talk about always the potential for long-term change, something that we don't know about. These have been around for a long time. Omalizumab has been around for a very long time, and so I feel comfortable that it's safe. But there's always the potential with other biologics. You're changing the immune system. What happens in 20 or 30 years? There's any medication, an unknown potential for it, and I think it's very small, but patients should be aware of that. And what else did I? Oh, there's always the potential of making things worse, right? So with dupilumab, you can unmask EGPA. Very rare, but it has been reported, and I've seen it. Sometimes you can unmask this where patients can get worse, and they have a undiagnosed EGPA, and then you have to switch up treatment. It's a potential, but also rare.
Another question is, what factors in history and physical exam suggest that a CRSwNP is not Th2 phenotype, so not T2? Another really good question. It's important to note that if it is a CRSwNP in the US, most of them, 87–90%, are type 2, but not everyone. We definitely know that patients from Asia, especially from parts of China and even other parts of Asia, are more non-type 2, even though they're starting to become more type 2. Things in your history and physical that may suggest to you non-type 2, eosinophil counts being less than 150, IgE being low, but not always. These people are older, and in asthma it's been much better described, often obese women getting it later in life, often with getting more bacterial exacerbations compared to someone who's more type 2. I think those would be the main ones. Anything else you can think of? Should we keep going? We have lots of questions.
Do we have time? 3 minutes. Okay. How long must the biologic be continued for, and what is the estimate cost per year per patient? Well, the studies, there's different studies looking at how long it has to be used for. Now, some of the early studies, when they came off the biologic, the symptoms, the polyps returned, and you started approaching back to baseline. Although there are some more recent data that I've seen that we looked at that even when they came off, patients still had improvement. The answer is I don't think we know yet how long you have to be on it. And I have colleagues who have tapered off, and patients are doing well after a number of years, but it's still unknown.
I 100% agree. I think for asthma, we've been using them longer, and I'll tell you, many people don't stay on them. It's very patient-dependent, and it's something that we'll find out. I definitely taper my CRSwNP dupilumab. I start every 2 weeks. After a year, I go to every 4 weeks. In some, I go every 6. But beyond that, the Netherlands study where they went much longer, I haven't done. However, I will tell you, these are all home injected. I wouldn't be surprised if people do their own, however they taper, same as they do, or how often they take it and want to extend it.
Okay, thank you for your attention.
That wasn't bad. We have lots of questions, but we'll go.
Okay, so 1:30, so breakouts you can go.
Seiji.